Everyone, and welcome to ASPE's webinar. Okay, the content of this event is solely for the purpose of education and information and does not constitute any personal diagnostic advice or personal medical advice, and that includes from our presenter. And with that, I would like to introduce to you Mark Lichty, who is the chairman of ASPE International.
Thank you, Joe. And I want to welcome each of you to this webinar today. This is a really important webinar. And there's so much that we can learn from one another. ASPE was created by men who have been on active surveillance and studied active surveillance. We have no financial motives. We're driven by our intense desire to help you forge a path that makes it easier for you. We know that from our own experience of having journeyed through these anxious months and years and found some peace, that there is a path to peace in living with active surveillance. Our purpose is to help men navigate active surveillance, educate men on the latest technologies, and learn from one another. I've learned in my own 16 years on active surveillance that much of my initial anxiety was wasted effort. I also learned that the prostate cancer world changes quickly. Active surveillance is a dynamic field. 4 years ago, there were only a few men who were Gleason 7s that were going on active surveillance. And now it's not uncommon for men with a 3+4 to go on active surveillance. We're hoping that by the end of this call today, you might feel more comfortable than you did at the beginning of the call. We sincerely believe you too can thrive on active surveillance. You can have an abundant quality of life, and you can find a peaceful vigilance in the process as we have. We want you to feel that this ASPE is your organization. As an example, David Keller, who's coordinated this whole thing and reached out to Dr. Klein, he was one of you just a few months ago. He was in one of our webinars and now has stepped forward and now is actually heading up this entire webinar. And so there's really an opportunity for each of you to contribute with ASPI, and we certainly invite you to do that. With that, I'd like to introduce David Keller.
Thank you, Mark. I want to welcome everybody again. It's very exciting to have you here. I'm very excited to be here. This is the leading edge of active surveillance for patients and urologists with Dr. Eric Klein. Dr. Klein is the chair of the Glickman Urological and Kidney Institute at the Cleveland Clinic. And it's my honor and pleasure to meet him. And you'll see under his photograph that he's known as a urologist. The way I met Dr. Klein was that my urologist of 30 years in Florida said, well, I want you to meet my urologist, Dr. Klein. So that's how I met Dr. Klein, was through my urologist, because my urologist was going to him as his urologist. So Dr. Klein is phenomenally well known in the industry. He is interested in cancers of the prostate, testes, kidney, and for many years he's been listed in the best doctors in America. Of course, he's board certified in urology. He lectures nationally and internationally. He was on the he led the National Medical Committee for the National Cancer Institute Select Study on selenium and vitamin E. And most recently, just in June of this year, he was, news of his study that he led went around the world. He was a lead author of the recent GRAIL study, which proved that a blood assay could be used to help detect 50 cancers at an early stage. He's just a leader in the field. We're really, really honored to have him here. He's also the editor of Urology publication. You can read all the other degrees and credentials and awards that he has received in this slide. But without any further ado, I would like to introduce you to our featured speaker, Dr. Klein.
Well, thank you for having me. I'm delighted to be here and to address this important topic that's playing an increasing role in men's lives. So let's see, let me get my slides up here. You confirm for me, someone, that you can see my slides? Yes.
Yes, we can see your slides.
And I'm speaking to you all from sunny and beautiful Cleveland, where I have been for the last 32 years on the faculty at the clinic. So let me begin by saying that as a urologist and even as a patient, we really only want to treat those cancers that have metastatic or lethal potential, and we want to put everybody else on active surveillance. And so I'll show you a cartoon that's familiar to some of you at the end of my talk. But the first question that you should have when you are diagnosed with prostate cancer not is, am I going to die of the prostate cancer, but does my prostate cancer need to be treated? Because we have learned over the course of my 30-year career that not all cancers need to be treated. And I'll give you some background. I started my career on the faculty at the Cleveland Clinic in 1989, which is when PSA became available widely. And back in that era, we thought that every cancer needed to be detected and that every cancer that we detected needed to be treated. And we have learned otherwise, and the field continues to evolve. The reason that we can say that we only want to treat cancers that have metastatic or lethal potential is that we know that most low-grade cancers and increasingly recognized a number of intermediate-grade cancers are not destined to threaten the life or the health of patients. And there are really three sources of information on this. Two are actually large observational studies from the University of Toronto and Johns Hopkins, which showed in about 1,000 men each that surveillance was safe. More importantly, the highest level of medical evidence we have always is called a phase 3 randomized trial, and this was done in the UK, the PROTECT trial, which showed that men with early stage prostate cancer treated with surgery or radiotherapy or active monitoring, what was sort of loose active surveillance, your likelihood of being alive at 10 years, that's Kaplan-Meier curve over here, where you can't see any difference in the survival rates between these three. The likelihood of being alive over the years was the same, regardless of how you were managed. On the other hand, patients who were managed with active monitoring or active surveillance, as you see here on the dotted line, about 10% of them actually ended up with metastatic disease or dying of cancer. And so there's good news and cautious news in this slide. One, it says overall as a management strategy, if you pick the right patient, active surveillance is right. It's the right thing to do, but it also says that there's a subset of patients, these 10% who got metastatic disease or died, need to be identified early in the course of disease so that they can be treated as appropriate, or they need to be identified while you're being followed so that they can be treated to avoid metastasis or death. And I'm going to talk about two tools to add to what we know about the histology of prostate cancer to help us make that decision better than we used to be able to. So the good news is that use of active surveillance, at least in the United States, is rising rapidly after being underutilized. It's recently, it's about 10 years ago, you can see for low-risk disease in the black line here, that almost half of all men with low-risk prostate cancer are managed by surveillance. So there's opportunity to continue to improve that. Use of surveillance in intermediate risk patients has been low and flat, but growing. And again, I'll show you the new tools that we'll talk about that allow us to broaden those criteria. And appropriately, patients who have high risk cancers, high grade or high PSAs are still being treated and not managed by surveillance. And that's highly appropriate. So it's important that we understand what active surveillance is. It's not a treatment, it's a management strategy. And what it means is that after initial diagnosis, you get no initial therapy, no radiation, no surgery, no other kind of treatment. And you are monitored on a regular basis, serial monitoring, to detect progression, to determine if the cancer that you have has progressed to the point where it could become potentially lethal and do you harm. And so I call that biologic potential. Some people call them actionable cancers. Some people call them clinically relevant cancers. But I like the term biologic potential because all cancers are clinically relevant, whether they're low grade and will do you no harm. The mental part of being diagnosed with cancer has real clinical significance. I talk about biologically significant cancers, and I mean cancers that need to be. And then should progression be detected by the variety of means that we have, then surveillance is intended to have curative intervention. So that's about the best way I can boil it down, these 3 bullet points about what active surveillance is, and I hope that that's clear to everybody. What does successful active surveillance look like? Well, it is the delay or avoidance of treatment-related side effects. That's really what it's about. All treatments have side effects. I'm frequently asked, which is the best treatment for a particular cancer? And the good news for prostate cancer patients is that there are 2 parts to that question. One has the best cure rate, and which has the lowest rate of side effects. And so the answer to the first question is they all have good cure rate, radiation or surgery, and you can make your choice. And I often liken that to, if you had a big pile of money and were in the market for a car, would you buy a Ferrari or a Lamborghini? Because all of them are good treatments. And the answer to the second part of it is that, which has the fewest side effects? The answer is none of the above. They all have side effects. And so you only want to be treated and cured of a cancer if the cancer is likely to do you harm. If the cancer is not likely to do you any harm, then it's the side effects that do you harm. And that's why you want to avoid treating them. So successful active surveillance, some patients go on their whole life and never need treatment. Patients end up needing treatment after a few years, and that's perfectly fine. That's still successful surveillance because the side effects have been delayed and the patient's life has not been put at risk in the meantime. What does failed active surveillance look like? Well, dying of prostate cancer, getting metastatic disease is a failure. And I personally think that if you have a rising PSA after a prostatectomy or radiation when you've been on surveillance, that you have that's failed active surveillance, and we want to avoid doing that. And the last part of active surveillance that I think about is what are the desirable goals? We really want to avoid undertreatment. And we can be fooled, and I'll talk about undersampling at the time of initial diagnosis. Prostate cancer can hide. You can have a lethal prostate cancer that's not very big, that's not seen on MR or is missed by biopsy. We need to be very diligent about identifying those patients who have biologically significant cancers that need treatment. And then you want to minimize the risks of the follow-up regimen. And I think in the last decade, we've done a great job of identifying which men can safely start on active surveillance. We do a great job with that now. We have really well-defined criteria. What we don't have a good handle on yet is how often people need to be followed and how aggressively they need to be followed. And that's not going to be the same for every patient. So if I have a 75-year-old man whose PSA is 5, who had a negative MR, but had a biopsy that showed 1 core of Gleason 6 cancer, that's not someone I'm going to pay very close attention to. Back when we started active surveillance, we used to biopsy everybody every year. And clearly that's over investigation for a patient like the one I just described. On the other hand, if I have a 50-year-old man who's got 30 or 35 years ahead of him, who has a PIRADS4 lesion on an MRI that on biopsy has 4 cores of Gleason 6 cancer, that's someone I'm going to watch more closely and see every 6 months and do an MR every year and be diligent about biopsying that patient on a regular basis. Although I don't think we know what the right interval for that is, whether it's once a year or once every 3 years. But that's someone I'm going to pay more attention to. And so I think the challenge in the next 5 to 10 years, as we manage an increasing number with surveillance, is tailoring the follow-up regimen. How do we use biomarkers? How do we use MRI? How often do we biopsy? What sort of biopsy do we do? And so forth. I think that's the biggest challenge currently. I also get a lot of questions about whether or not it's safe for younger men to go on surveillance. And with the idea being that you'll have fewer treatment-related side effects with surgery, for example, you're treated when you're younger than when you're older. That's true. but still avoiding the side effects is still the best thing. So there are a number of studies in the literature. This is one from the University of California, San Francisco, that was published a couple years ago, that showed that in fact, in the blue line here, you can see that younger men, those under 60, actually did better on surveillance, were less likely to progress to the point that they needed treatment, even though the overall treatment rates were the same. So I personally don't have any age restrictions on putting patients on active surveillance. The whole theme of my talk will be here, the way I manage patients. It's really about being sure that the whole biology of the prostate and the cancer that an individual has been sampled. And it's the biology of the cancer that should dictate how the patient is managed. And we have a number of new tools that help us assess the biology of the cancer. So this is my algorithm for selection of patients on active surveillance and how I follow them. And it starts in this blue box. You need to have two things to go on surveillance. First, you need to have a biologically indolent tumor, one that not only appears low grade under the microscope, but lacks molecular features of aggressiveness. And the second thing you need is a favorable mindset. You have to have the right psyche for surveillance. Not every patient is in the right mindset for surveillance. They hear the word cancer, they can't get it out of their mind. It inhibits their ability to be engaged with their families and their work and with the world at large and so forth. And so there is the occasional patient who has the right tumor, but not the right mindset, despite education, who is disqualified from surveillance. And so how do we define biologically indolent tumor? Well, these criteria are well established now, but they are evolving. So biologically indolent tumor primarily is low volume grade 6 or Gleason grade group 1 disease. And increasingly patients with Gleason's 3+4 or Gleason grade group 2 with small amounts of pattern 4 cancer. So I consider anybody under 10% pattern 4 to potentially be a candidate for surveillance. The third one here is one, though, that's going to revolutionize what happens in the future, and that's the cribriform or intraductal histology. These are specific cellular patterns that a trained pathologist can see under the microscope. And we have a really outstanding pathologist at the Cleveland Clinic named Jesse Kenny, who is in the process of re-reviewing lots and lots of biopsy slides. And in the next couple of years, I think we're going to see recognition of his work. If you don't have cribriform glands, it almost doesn't matter whether you have grade 6 or grade 7 cancer. It's the presence of this cribriform histology that determines the aggressiveness of the cancer. And in some preliminary data that he hasn't published yet, which I've seen, he's able to take patients and sort them into favorable histology and unfavorable histology and almost get perfect separation between them. So what we use from histology is going to evolve over the next few years. Generally speaking, you should have a PSA below 10 for an average size gland, a PSA density, which is the volume of your prostate divided into the PSA in the blood, of less than 0.15, and a normal feeling gland. Those are the criteria that I use currently. And usually when someone is initially diagnosed with one of these, with a biologically indolent tumor, at least in the past, we've done a confirmatory study. In the era before we had MR-guided biopsies, that meant a repeat random biopsy done transrectally. That's falling by the wayside because of MR. Almost everybody who's diagnosed with cancer now is diagnosed by MR-guided biopsy, and that's the way it ought to be. MR makes biopsy better. And then depending upon the patient, we'll talk about this a little bit, I use a genomic test that measures the molecular features of cancer. So one of the questions that I was cued in about that may come up is whether or not I would support the idea of Gleason 6 cancer not being caused cancer. And I do not support that. And the reason is there is an increasing amount of data that shows that even low-grade appearing cancers can have molecular features that are characteristic of high-grade cancers. And those are the patients who progress on surveillance. And those that have higher scores at the very beginning are less likely to be cured if they go on surveillance and then are treated. And I will show you that data there. So I think the idea of calling a grade 6 cancer not cancer just based on histology is not right. If you have a grade 6 cancer and a low genomic score, then maybe you could call it not a cancer, but that remains to be seen. So current guidelines suggest that someone who starts on surveillance be seen every 6 months with a digital rectal exam and PSA. Honestly, having managed thousands of patients with active surveillance, it's very, very, very rare to see much change over in 6 months. The reason for the visit perhaps is less about assessing the actual progression of the cancer and more about being sure that the patient doesn't get lost in follow-up. And then, at least until recently, at a year, it's a repeat PSA, another MRI, and if the patient has a repeat biopsy, a genomic test so they monitor for molecular changes over time. And this gets iterated. And so the idea is if you get through that first year, you get seen at 18 months and then 24 months and that sort of thing. And we would treat or intervene to cure the patient if a biologically significant tumor is detected on subsequent biopsy. And what that means is higher grade cancer. To some people, it means an increase in volume of grade 6 cancer. That's a little bit controversial. And what we don't know is if your PSA, starts at 8 and you have low grade cancer, and at a year your PSA is 12, is that meaningful? Most PSA comes from BPH, not from prostate cancer. Or what happens if your PSA density goes over 0.15? Those are sometimes used as triggers for treatment, but those aren't direct measures of the cancer biology that I'll be talking about. So how do we define biologically significant tumor? Who do we know is not a good candidate for surveillance, assuming that they're young and healthy and have a 10-year life expectancy? I think these are pretty non-controversial. What I have on the slide here is Gleason 4+3 or higher. Those are patients who need treatment. And any study that suggests that you have disease outside the prostate, if your cancer goes through the rind around the prostate, that's called extraprostatic extension, or if it's in the seminal vesicles or in the lymph nodes, those are exclusions from surveillance. And what's important is that these should exclude you from surveillance, whether they're present at the time of your initial diagnosis or if you progress to those while on surveillance. And so these would be definite triggers for treatment, in my view. So again, just to focus on what should trigger treatment. In the past, an increase in volume of grade 6 disease has been considered a trigger. So in the past, if you had 1 core of Gleason 6 and a repeat biopsy a year or 2 or 3 later showed 3 or 4 cores, then that would trigger treatment. What we don't really understand, honestly, if that represents true biologic progression. And that's where the genomic tests come in and help us, because it's possible that you had all that grade 6 cancer on your initial biopsy and it was just undersampled. I think there's general consensus still that an increase in grade from 6 to 7 ought to trigger treatment, although again, it depends on what the histology looks like. And I say worrisome increase in PSA, that comes from experience. We see PSA fluctuate all the time for reasons that we don't fully understand. But with 30 years experience, what I often say to the residents who are with me in clinic, when they describe a patient to me, I said, does this smell like progression? Which doesn't sound very scientific, and it isn't. Even though there are some dogs that are being tested that can smell cancer-related substances in urine and breath and can pick up cancer, clinicians are not able to do that. And I want to show you the last bullet point, an increase in genomic score and how useful genomics are. And you may not have heard that from other speakers. I heard about the debate between Dr. Klotz and Dr. Egner, and for reasons only known to them, they are not so interested in the genomic scores and the molecular features now. And I think we need to embrace that and understand how that helps us. One other common question is, what about serial MRIs? If I had an MRI at the time I was diagnosed that showed no lesion, and a year or 2 later, it shows a new spot that's biopsied and shown to prove cancer, do I actually need to have that biopsy? If I had nothing a year ago and now I have a lesion that's a PIRADS 4 or 5, that mean anything? And more importantly, maybe, is if there's serial MRs that are stable, does that mean you don't have progression in your cancer and don't need a biopsy and don't need treatment? Or what about tumors that disappear on MR, a PIRADS 4 or 5 lesion that disappears? And there's not much data on this. There's been some publication from Sloan Kettering, and this one came from Mark Emberton in the UK. This was the first one. that showed in patients on surveillance what the annual percent change in tumor volume was in people who had targets. And you can see it's all over the map. I mean, some stayed stable, some decreased, some increased. And then this was the annual change in tumor volume between the first and the last scan. They're separated out by several years. And again, some got bigger and some didn't change and some decreased. So what do we do with a patient who has a Gleason 6 cancer and a PSA of 5, who had a PIRADS 5 lesion on biopsy, and a year later, that PIRADS 5 lesion is smaller? What does that mean? And so the answer is we don't really know. And I think the general consensus about MR is two things. It does not see all high-grade cancers, and you can't really use changes on MRI over the course of time to determine whether or not your cancer has progressed. The value of MRI is to be sure that you haven't undersampled the high-grade cancer in the prostate. I think it has fallen out of favor, certainly by me and many of my colleagues, as a way of saying yes or no, you don't need a biopsy, or yes or no, your cancer's stable. It just simply doesn't see the cancer biology. There are a lot of things going on in an MRI that dictate what a radiologist sees that may have nothing to do with cancer. So while MRI has been a major advance at initial diagnosis, it has not replaced the need for biopsy or other biomarkers in the course of active surveillance. And so I want to focus on some tools that help us decide who has a biologically significant cancer. Remember, I said that at the beginning that if you have a biologically significant cancer on biopsy, whether that's at the time of initial diagnosis or at the time of a follow-up evaluation, that would be the time to trigger. And so histology, that means that's Gleason score, what the pathologist sees under white light microscopy looking down the microscope. It's informative in many cases, but it doesn't tell the whole story about the biology of the cancer, and neither does MRI. And I always get back to this fundamental observation that was made many decades ago, is that cancer is a genetic disease. It's not a radiologic disease. Cancer isn't driven by what you see on an MRI or another X-ray. It's driven by the genes in the cancer. But when I started my fellowship at Sloan Kettering in the mid-1980s, I spent an entire year growing solid tumors in tissue culture and harvesting their chromosomes and cutting out their chromosomes and putting them together like this in what's called a karyotype. And what you see here is what chromosomes from a normal cell look like. And what you see here is what chromosomes in a cancer cell look like. And you don't need to be a scientist to see the difference. And the idea here is that when the chromosomes and the genes that are on them start going haywire, that's when cancer can grow and progress. And looking at a biopsy under a microscope sees some of this, but not all of this. And MRI doesn't see all of it either. And so we have this whole new set of genomic tests that will tell us what the real biology of the cancer is and who's safe to follow and who can be treated. And so when I talk to my colleagues, I show this slide and I say, the era that we've grown up in until recently was right here, right? We knew we had cancer when we saw cancer on a biopsy. That's histology. When a cancer starts, the cell starts out looking normal, and then it looks like a cancer cell, and you need a trained pathologist to look at a biopsy under a microscope and see the histology. Well, those changes at the single cell and small number of cell levels happen before they can be detected by PSA. So you can have a small cancer in your prostate and have a normal PSA. And they certainly have to reach a certain size before you can see it on MRI. And it's not until these two things happen that you clinically detect the cancer, right? So we don't know that it's there until the PSA goes up or until it shows up on an MRI. But what we have developed in the last few years is this new tool that's all the way over to the left of this timeline here that gives us a window into what's happening at the chromosome level, what's called the gene expression level, at a step before even a pathologist can see it under the microscope. And these are called genomic tests, which I'll talk about. I think ought to be a standard management of patients on active surveillance because they tell us about the biology of the cancer in a way that's additional to all these other things. So histology is useful if you have low volume grade 1 disease and a negative MRI. You probably don't need a genomic test. Most of those cancers, what we call those low grade cancers, those are the ones that probably could be labeled something other than cancer. And histology or biopsy is very useful if you have a Gleason 4+3, Gleason grade group 3 or above. We know that those cancers need to be treated. And as I mentioned, that's cribriform and intraductal histology. If that's seen on biopsy, you have a cancer that needs treatment. But there are a lot of times when histology is not very useful. If you have, this is a common scenario that I see in my clinic all the time now, someone with a PIRADS 4 or 5 lesion on MRI, 5 or 6 biopsies right through the lesion. So there's no question that the area of cancer was biopsied, but it's all grade 6. So that's high volume grade 6 disease. What do we do with that? And what I can tell you is that some of those are real tumors that need treatment based on their molecular features. Some of them are not. Some of them can be followed, and that's where genomic testing is. And then, as I mentioned, low volume Gleason's grade 2 or 3+4, patients with less than 10% pattern 4, and maybe even more than that, if they lack cribriform histology. That's the sweet spot for genomic testing. And this is what I think the paradigm is now. And I know that not everybody agrees with this, but this is the way I manage my patients. So the challenge when we consider someone for active surveillance is undersampling. We have this whole prostate that may measure 40 or 50 or 60 grams in size. And we use a needle that's only a few millimeters in diameter and can't possibly sample the whole prostate. But we know that we're not missing a high-grade cancer. And so there are two kinds of undersampling. There's biopsy undersampling, and we need to know whether or not the needle hit the highest grade cancer. And then we have what I call biological undersampling. What's the true biologic potential of the tumor in the prostate? And again, these genomic pools are useful for answering the question. So to get past biopsy undersampling, we have MRI. And increasingly, we're doing transperineal biopsies where the needle doesn't go through the rectum, but it goes through the skin between the rectum and the testicles. That's a more accurate and safer way of sampling all areas of the prostate. And there's no question that this has been a major advance and that biopsy undersampling is less of an issue. And to address the issues of biologic undersampling, when you have a biopsy that shows only low-grade cancer, and you have a good pathologist, but you also know that the pathologist using a microscope can't really see the chromosomes, we have these new tests, these 4 that are on the market, genomic tests, that assess the aggressiveness of the cancer. And so to get back to this question about whether or not grade 6 cancers ought not to be called cancer, when you look under the surface of grade 6 cancers, this is a nice study done at UCSF, and you use these new molecular tests, 15% of men who would otherwise be considered for active surveillance had high risk features. Their chromosomes were starting to go haywire, not picked up by MRI, not picked up by the pathologist. And it's not that they were wrong, it's just that this is a different way of looking at the tumor. So for this reason, I do think that grade 6 cancers still should be called cancers until you have measured directly their biologic potential at a molecular level. So if you have a grade 6 cancer that has a low genomic score and you don't want to call that a cancer, I'd be okay with that. But if you have a grade 6 cancer with a high genomic score, that's something that should be paid attention to, and that's a real cancer. So the question then comes up is, if you have a biopsy that has a high genomic score, what do you do with that? If you have a low-grade cancer, Gleason 6, that has a high genomic score, what do you do with that? Well, people react to that information differently. My own bias is that those patients all need treatment, and I'll show you some data to support that. Some people would say, well, you look a little harder and rebiopsy the patient to find the high-grade cancer that you missed, and you don't treat the patient till the high-grade cancer comes along. Or a developing area, one that I addressed earlier, is if I have a 50-year-old with a Gleason 6 cancer and a low genomic score, I probably can follow that patient a little less intensively than someone with the same feature and a high genomic score, because a high genomic score again indicates that the the chromosomes are starting to go haywire and they might need treatment. So those are 3 ways you can react to that. And it depends a little bit on the philosophy of your urologist. So we have these two tools, MRI and genomic tests. And for many years now, there have been arguments about which is better and do you only need one. And I've always thought from the very beginning of the availability of these, that these are complementary tests and not competing tests. And I say that if you think about what they offer to an understanding of your cancer, that you would consider that you would want, if you're embarking on this journey of surveillance, you would want to know everything possible about your cancer to be sure that it's safe for surveillance. And if you had one signal out of all the things that we look at that suggested, gee, maybe this is more aggressive than it looks like, you might want to get treated. That's generally how I look at it. So what's the added clinical value of MRI? Well, it makes biopsy better. There's no question about that. It simply has not lived up to the expectation that it can eliminate the need for biopsy forever if you have a negative MRI. That's wrong. The genomic tests reveal the biologic potential of the tumor. That's different than what MRI does. MRI is highly operator dependent. I work at a great place at the Cleveland Clinic, and we have really high quality radiologists, but I can tell you that there are differences amongst the ability of our radiologists to identify biologically significant tumors. And when I get an MRI read that's inconsistent with all the other clinical information I have one go-to guy who I think is the best, who actually outperformed an artificial intelligence algorithm in a study that he was in. And I asked him to look at the MRI. And in smaller community hospitals, this is a challenge. If you don't have a really experienced radiologist, the MRI doesn't give you as much information as you hope. On the other hand, when you take a piece of tissue and you measure the chromosomes that are in the tissue using established clinical lab methods, that's completely objective. You don't need a highly trained pathologist or radiologist to look at a biopsy or to look at an MRI to get the correct read. Well, that's another advantage of genomics. In the past, MRI required a second biopsy, and I probably should change this slide because that goes back to the era where we did transrectal biopsies without MRI. So it probably doesn't do that. But one of the advantages of genomics is that you can get this genomic read on the biological potential of your cancer on the initial biopsy, and you don't need to be re-biopsied. It's very clear that MRI cannot predict what might happen to you in the future. There's no data, and there have been studies that looked at this. There's no predictive value. If you have a negative MRI now and a biopsy, Gleason 6, that's not enough information to know that you're never going to progress. On the other hand, genomics has been shown, and I'll show you some data, to predict the likelihood of having a PSA failure. That's what BCR stands for recurrence, and your risk of metastasis and your risk of death. So this is the way I look at it. If you've got a big white shark like Jaws in your prostate, and it's got this big fin above the water, MRI will see that, and you will know that you have something to worry about. On the other hand, genomics allows you to look at all the garbage that's underneath the surface that MRI and other things cannot see. So again, they're complementary, and they give you lots of information. And when I see a patient on active surveillance, because I don't want to make a mistake and put someone's life at risk, and because I want to be able to assure the patient that we have all the information that's necessary, that needed to make a decision for surveillance, I generally order both tests. I think they're both important. So here's let me finish up with some little bit of data that's just been published recently about genomic tests. And this is some data using Oncotype DX. Let me say the available tests on the market are pretty similar to each other in terms of their ability to predict outcomes. Oncotype and Decipher, there's been a lot of study on those. What we looked at were patients, about 500 patients that we developed the Oncotype test on. And that was so long ago now that we have 20 years of follow-up on those patients. And we looked back and said, let's look at the GPS score on that biopsy that was taken from their prostate sample and see what happened to them over 20 years. And what you can see here is that if the GPS score was below about 25 or 29 or so, the likelihood of getting metastatic disease at 20 years was really, really low. And whereas if your score was above 30, even if you were treated, likelihood of getting metastatic disease was high. And on the right side of the slide, you see the same data for dying of prostate cancer. So again, if you have a biopsy that shows an Oncotype score below about 25, your chance of dying of prostate cancer at 20 years is almost zero. Whereas if you have a biopsy, even if it's a Gleason 6 cancer, that some people don't want to call cancer, and you have a score of 35 or 40, that is a biologically significant tumor where you have a measurable chance of dying of your cancer. And that's why I think if you have a high score, almost regardless of what the biopsy shows, that you ought to be treated, because it's helped risk stratify who has the most aggressive cancers and who doesn't. Here's some other data. I don't know if this has been published yet, but it was shared with me by Dan Spratt, who is now the chair of radiation oncology at Case Western Reserve University, using one of the other genomic tests, the Decipher test. Again, same idea here. These tests measure things that MR doesn't see. They measure things that a pathologist cannot see, not because they're not qualified, it's because they can't see chromosomes. And if you have a low Decipher score, it's like having a low Oncotype score, and vice versa with a high Decipher score. So these were patients managed by active surveillance. And you can see that if you were a candidate for surveillance with Gleason 6 cancer or low-lying Gleason 7 cancer, and you had a low Decipher score, that's the blue line here, you stayed on surveillance longer than patients who had a high Decipher score. So if you had a biopsy Gleason 6 with a high Decipher score, your likelihood of being off surveillance in 2 years was 50%. And that means that within that 2 years, you had another biopsy that now shows higher lying Gleason 6 cancer or a higher grade cancer. And that the Decipher score done on the initial biopsy back here at time 0 was actually able to predict that. Here's what's more important data is on the other side of the slide. If you started on surveillance and you ended up getting treatment, what would your likelihood of being cured? Well, if you had a low Decipher score, that's in blue here, even if you progressed, started with a low Decipher score and you progressed to the need for treatment based on biopsy, you had virtually 100% chance of being cured. Whereas if you started with the same biopsy and had a high Decipher score, then your risk of not being cured at, I think about 2 or 3 years out, is about 30%. So that suggests to me, just as the previous slide did, that if you have a low genomic score at the time that you go on surveillance, you are safe for surveillance. And you're not going to lose the window for curability if you get to the point where you need treatment. Whereas if you have a high score, that's someone who needs more attention. And it's not that you're definitely going to die of your cancer, but it's likely that you're going to end up needing to be treated at some point. And I would argue, if you're pretty certain about needing treatment, why not do it as early as is appropriate when you know that you have a biologically indicated. So I love this cartoon, which was actually published in the New Yorker 21 years ago. And this was science fiction 21 years ago. It's a woman going to the pharmacy saying, here's my sequence. Well, this is this common part of oncologic practice now. Maybe some of you have used the same technology with 23andMe, which provides interesting ancestral information, but not any useful medical information. There are lots of tests available now based on your DNA sequence that gives us lots of useful information, and particularly for active surveillance, and that's what I just showed you. And I can just imagine in the lifetime of our children with certainty that having your whole genome sequenced and having that be part of your medical record, your electronic medical record, is going to be deep and routine and be very useful for managing all sorts of diseases, including prostate cancer. And then finally, I hope Mark is smiling, because I was just surfing the internet earlier this morning to come up with a good cartoon to finish with. And I stole this from you, but I have the correct reference on the bottom there. And probably all of you who started on surveillance or considered it went through this same progress that Mark has described here as, gee whiz, I was just biopsied with cancer, will I die? And then Your doctor says, no, you're not going to die of prostate cancer. You have a low-grade cancer. And what you can do to help manage it actively is to stay healthy. I'll change my lifestyle. I'll eat right and I'll exercise. And, I'll be nice to my spouse and all of those things. There are no atheists in foxholes. Then you join a support group like you have here, so you can talk to someone who has been through it for a few years and can tell you what to expect. And then you can get to the point, this is something that we haven't figured out yet in surveillance. Can we eliminate the need for biopsy completely? There was hope early on that MRI might be able to do that, but it can't. There are some other markers that are coming on the market soon that might be helpful and so forth. And ultimately, you can be very happy having looked backwards for 12 or 16 years on surveillance. So I will stop there. And I am happy to take whatever questions come along here, either through the chat box or, verbally at time with me.
Dr. Klein, this is David Keller, and thank you so much. That was a fantastic presentation. I've learned a lot, and I've been doing a lot of research over the last 2 years. This was chock full of new information for me, and I'm very, very grateful for it. And we've had some monitors monitoring the chat box, and our first monitor is going to be Phil Siegel. We're going to prioritize questions that come in through the chat box. So Phil, I'll turn the microphone over to you, please.
I know Dr. Klein talked about active surveillance, and one of the things is that men have to have the right mindset. So Jim asks the question, what are medical professionals doing to actually educate men about the benefits of active surveillance? That, in other words, getting rid of the mindset that says, it's cancer, it has to come out.
Yeah, that's about education. It's about doing seminars like this. It's also about professional education of the physicians. And so the American Urological Association, which is our professional organization, has put a lot of effort in developing the right guidelines and having education sessions and so forth. There's no one who trains currently in urology as a resident or fellow who doesn't learn about active surveillance. And it's taken a little more time to get people who trained several decades ago to understand it and so forth. But it's really about looking at that big data, the PROTECT trial and the Toronto trial and the Hopkins trial, show people that it's safe and to learn how to do it.
Great, thank you. Is there a different approach with regard to African-American men and active surveillance?
Yeah, that's a great question. It has been in the past believed that African-American men have tumors that are biologically more aggressive, but that in fact doesn't appear to be true, that it's more about seeking care and having access and so forth. So African-American men are equally eligible for surveillance as anybody else. Again, it depends on the biology of the cancer.
Okay. Another question, you talked about biopsy, so a couple of questions. I know ASPE is really interested in the transperineal biopsy, and I just wondered what your feelings are with regard to that, and also perhaps you could discuss frequency of biopsies.
Yeah, so two separate questions. I think transperineal biopsy should be the standard approach now. We adopted this in Cleveland a couple of years ago. I think it's more accurate than even transrectal MR guided biopsy because there's less needle deflection, and there's no question that it's safer. So there's virtually no risk of getting a bloodstream bacterial infection from a transperineal biopsy, where a transrectal biopsy still has that risk. So it requires more expensive equipment and it requires a new skill set, and the urologic world is working on this, but I think within a few years it'll be the standard. And then the hardest question that's been asked so far is, how often should someone on surveillance be biopsied? And the answer is, we don't know. It started when Val Carter started this at Hopkins 25 years ago. The worry was, you don't want to miss even a single patient who had progressed. We didn't have very good biopsy techniques. We knew there was a lot of random error, but we biopsied everybody every year, and that clearly is not necessary. And so the answer is we don't really know, but I use an individual risk stratification now, as I alluded to early in my talk. Again, if I see a 75-year-old who has, some heart disease and is an estimated life expectancy of under 10 years and a small amount of grade 6 cancer and a low genomic score and a negative MR, that's not someone I'm going to biopsy frequently or maybe ever. Whereas a younger man who has more to lose in terms of life expectancy, who started with a higher volume of cancer, maybe a 3+4 with no cribiform and 5% pattern 4 and an intermediate genomic score, that's someone I'm going to follow closer and probably biopsy more frequently. But whether that interval is once a year or whether it's once every 3 years, we haven't figured out yet. What various groups are working on now is to use artificial intelligence to create an algorithm that has all the inputs, the age of the patient, the initial biopsy characteristics, the MRI findings, the genomic score, the PSA, the change in PSA over time, to predict at any given 1 year interval, for example, if I were to rebiopsy this patient now, what's the likelihood that this particular patient would reach a trigger for treatment? And I think that approach is going to come online in the next few years and be helpful in deciding whether or not a biopsy is necessary. And it'll be very individualized based on all the factors that I mentioned.
Thank you. One other question on, we've done a few seminars on micro ultrasound. And perhaps you could discuss whether that is that a standalone or should be used in combination with MRI?
Yeah, micro ultrasound is very interesting technology. We have some experience and some publications with it. Our current ultrasound probes are 9 megahertz and can see some internal architecture of the prostate. A micro ultrasound, the device that's available is, I think, 29 megahertz, which is far more powerful and can see things in the prostate that cannot be seen by standard ultrasound. There have been done and some planned head-to-head studies of micro ultrasound guided biopsy without MRI, and to see whether MRI adds anything to micro ultrasound. The hope is, we haven't realized this yet, the hope is that micro ultrasound will be equally good to MRI and could eliminate the need for MRI. And the advantage to that would be you would not have to send a patient to have an MRI, wait to have it read, and then schedule the biopsy. You could just do it all in one. I would say the early data look very promising in that regard, but there's more study that is needed to know that for sure.
Okay. And I guess one of the last questions, you talked a lot about genomic testing. So, and I think that you're definitely a fan of genomic or genetic testing. Although I guess in Canada and in Europe, that's not quite, I'm not sure the word accepted is the correct word, but yeah, it's certainly not as a positive a view of it as yours. I just wonder whether you might want to comment on that.
Yeah, so let me couch it in two different ways. And one is, I was not a huge fan of active surveillance 20 years ago when I first came along. And the reason is that we all had experience having done lots of prostatectomies on men who had low volume grade 6 cancer on biopsy, who had a lot more aggressive cancer in their prostate. And at the time, we didn't have ways of picking that up. And so I wasn't very excited about the idea of surveillance because I didn't want to put anybody's life at risk. We started working with some companies, Oncotype and Decipher in particular, to help develop this tool that can help tell you on the initial biopsy whether there's higher grade cancer in the prostate. And it works. And then I got to the point where I would ask a patient or ask myself, if you were a patient who had a biopsy and was considering surveillance, who had an MRI, wouldn't you, and you know that 15% of low-grade cancers have molecular features of high-grade cancer. And you know that MRI doesn't see all high-grade cancers. In fact, MRI misses 75% of grade 4+3 cancers that are under a centimeter in diameter. why wouldn't you want as much information as you can possibly get about your current situation before deciding to embark on surveillance? And so, on the one hand, I think there are lots of urologists who don't really understand what genomics measures and therefore don't, grab what its utility is. And I think there's a wrong belief that MRI tells you everything you need to know about the prostate. Clearly isn't true. And the last couple slides I showed you with the 20-year Oncotype data and the active surveillance data showing that if you had a high Decipher score, you could have two patients, both with the same biopsy. One has a low Decipher score, one has a high Decipher score. The man with the high Decipher score is going to end up with a 50% chance of progressing to high-grade cancer on biopsy in 2 years, and has a 30% chance of not being cured when he has his prostatectomy or radiation. Why wouldn't you want that information? So this is like all new technology. There's an old Silicon Valley guru from a couple decades ago named Roy Amara, who said we tend to overestimate the value of technology in the short term and underestimate it in the long term. And that's where I think we are with genomics. I'm probably overly optimistic about its benefits, but in the long term, this is going to be a standard part of the management of prostate cancer.
Thank you very much. David, I'm going to pass it back to the second reviewer.
Thank you, Phil. Our second monitor of the chat box is going to be Jeff McLennan. Jeff, the mic is over to you.
Thank you, David, and thank you all. Doctor, what is your opinion on the use of a liquid biopsy, and how does it compare to these other indicators on prostate cancer?
Yeah, it depends. I mean, I like the concept of liquid biopsy, but it depends on which liquid biopsy test you're talking about. So there's a study called the Canary study, which was 1,000 men followed on active surveillance for about 10 years. And that group of people has done the best job of evaluating what liquid biopsies, urine-based biopsies are out there, and like PCA3, for example, and just found them not to be useful in predicting progression. So the concept is great. And I would say of the available tests on the market, there's none that really adds useful information currently, and certainly none that could currently eliminate the need for the occasional repeat biopsy or MRI. But that is where that's going to be the future of cancer. And David mentioned at the beginning this new test that a company called Grail has developed, a blood test that can find methylated DNA in the blood that's cancer specific, and it can detect 50 different kinds of cancers. And if you have a positive blood test that says you have a cancer, it can predict with 90% accuracy what organ system the cancer is in. That's pretty exciting. And we eventually will get there probably in active surveillance as well.
Thank you, Doctor. Are you concerned about the use of gadolinium with MRIs and other imaging?
Yeah, actually, no, it's turned out to be very safe. I mean, there was this old concern about one serious side effect, but it happens so rarely. Having said that, at least in the diagnostic setting, there's something called biparametric as opposed to multiparametric MRI, where the MRI is done without gadolinium. And if you have the right radiologist, that's almost as good. Radiologists would prefer to have gadolinium because what the gadolinium does is show you the blood vessel pattern in the prostate. We know that tumors have altered blood vessels, but a limited MRI in experienced readers' hands is unlikely to miss a PIRADS 4 or 5. And so it's probably just good without the gadolinium.
Thank you, Doctor. The next question comes from Wayne regarding the biology of prostate cancer for African-American men.
Yes.
Do you have a different approach and whatnot?
Yeah, so the answer is no. Again, it has been, African-American men have the highest incidence and death rate due to prostate cancer of any group in the world. And for many decades, we have believed that's because it has a different biology. But the reality is that it's probably more determined by different social attitudes about seeking care and suspicion of the health system, and about actually having access to care. And there's a lot of data in the VA system where access is not a barrier, where stage for stage and grade for grade and treatment for treatment, African-American men's cancers behave the same way as anybody else. So I do not believe that there are, at least as yet, identified really significant differences in the biology between African-American men and Caucasian men, and everybody is a candidate for surveillance.
Thank you, doctor. The next question of two that I have remaining are, how soon after the biopsy must a genomic test occur? And if so, do you have a preference of the genomic test?
Yeah, so the genomic tests measure the biology of your cancer in real time. So whatever biopsy you had recently is the one you want to do the genomic test on. So it doesn't make sense if you're 5 years down the road of surveillance to go back to your initial biopsy and do a genomic test. That's not going to help you tell what's going on right now. So usually within 6 months of the biopsy. Do I have a preference? Well, I have an intellectual preference for Oncotype and Decipher because I helped develop those. Having said that, I think they all perform at a pretty similar level. So any of them are fine.
Okay, doctor, and the final question I have for you is, do you ever refer to a therapist if you have an active surveillance patient on the edge of some kind of emotional problem?
Absolutely, yes. I encourage everybody to contact a local support group and to talk to people who have already faced the same issues and know what that individual is facing and so forth. And I think it's very helpful.
But you do not refer to a specific therapist or group of therapists?
I generally go, it depends on how severe the issue is. Mostly it's about education and talking to people who've been through the same experience, but I have the occasional patient who's so anxious about it that I might refer to a psychologist.
Thank you very much, Doctor. David, the mic is back to you.
Great, thank you very much. Great questions. Thank you out there to all of you. If you still have questions, there's still time to submit them into the chat box. And Dr. Klein, could you just talk about diet for a minute? Is there anything that you think people might do to give them a little bit of an edge? And you may have touched on this briefly in your talk, but if there's anything you could elaborate on, that would be helpful. Well, I'll just stop right there.
So let me say that a couple things. One is there are no specific foods to avoid or eat that will prevent cancer or prevent your cancer from progressing and all of that. It just isn't any solid scientific evidence on that. The second thing is that what's heart healthy and healthy for your general health is generally healthy for your prostate. So plant-based diets, Mediterranean diet, as a base are probably the most important things. What I find in patients on surveillance, you get diagnosed with cancer and you think you're a good person, and everybody goes through this, what did I do, to get this? How did that happen? And they feel out of control. So one thing we can all control is what we eat. And so I look at Mark's cartoon about, I'm going to change my lifestyle. Changing your lifestyle when you're diagnosed with cancer is less about the cancer and it's more about feeling more in control of your life and living your life more fully. And so that's why I think it's important. You mentioned the SELECT trial. We did this big trial where we compared 35,000 men taking selenium supplements every day and vitamin E supplements every day or both together. And we found actually that not only were they not helpful, but they were harmful. If you take high dose vitamin E, you increase your risk of getting prostate cancer. So it's more about control, right? And feeling in control and feeling physically better.
Thank you very much. That was a great answer, and I've learned something new just in that answer. So thank you very much. In one of your slides, you talked about transperineal saturation. I was wondering, as someone who has had transperineal saturation and quite a few cores taken out,
yes,
what do you consider saturation?
So, yeah, so that's a good question. I don't think we know the answer to that, but there are two scenarios now. Someone has an elevated PSA, gets an MR. The MR, if it shows a lesion, you're going to do the target lesions. We've learned, though, that MR doesn't see all cancers. You still need to do some random biopsies. How many? I don't know. The bigger problem is a patient with a worrisome PSA and a negative MR. What do you do? And that's where this idea of saturation biopsy comes in, where you target every few millimeters, every quadrant of the prostate. But I don't think we know how many is a minimum or a maximum.
Okay. That's a great answer, and I appreciate it. Another question that I have, and any member of our program committee or board that has come up with a question in the chat room or on their own, you can certainly take the microphone away from me. I have about 3 or 4 more questions and another group of questions I can go to, but from my list that I've made while listening to the presentation, Decipher, do they have a false positive rate?
Yeah, they probably do. I mean, no test is perfect. And so, yeah, and so there's probably the occasional, I don't know, it's probably rare to have false positive. I mean, I just have to say, of the patients that I've operated on who have had high Decipher or high Oncotype scores, there's rarely a surprise of, oops, you only had one spot of low-grade cancer, this overestimated. It doesn't happen very often.
Okay. Yeah, that seems pretty specific. Since it's at the genomic level, that seems pretty, to have a higher degree of accuracy.
So the bigger problem with genomic tests is if you have 2 tumors in the prostate, your biopsy needle only hits the lowest grade, least biologic potential. Does that happen? Yes. I don't think it happens often, but it's an issue. It's a limitation of the test. Just as the fact that MRI misses 20% of high-grade cancers is a limitation of the test. So it's interesting to me. Someone commented earlier about how MRI has been more widely adopted than genomics has. We accept the fact that MR is only 80% accurate, but if it's a negative MR, we say, don't worry. Whereas the genomic tests have been criticized by some people as, well, you have the sampling error issue, but it's the same sampling error.
Okay.
David, I've got a question for Dr. Klein about going on active surveillance. Someone with high volume Gleason 6, or let's say low volume 3 + 4 is 7, what are the factors to consider about going on AS?
There's only one. What's the biology of the cancer? And what's the most direct measure of the biology of the cancer is genomic test. That is the sweet spot of genomic testing.
Yeah.
That's the perfect way to use them to make that decision.
Great, thank you.
Just because you have a high volume grade 6 cancer doesn't mean it's aggressive. We used to believe that. Just because you have a low volume grade 6 cancer doesn't mean it's not aggressive. They're 2 different things.
Good point.
Thank you, Dr. Klein.
Jeff, you had a question. I have another question.
Sure. I can jump in. This is from Howard. Why are European and Canadian urologists less supportive of genomic testing?
I'm not the right guy to ask that.
Trying to create an international incident.
I'll tell you why. It's because I'll give you one answer, because I have this debate all the time with my colleagues. They think that they're smarter than the tumor is. Right? That's what. So I don't believe that. I'm not that smart.
I think one, if I may make a comment, I think one other reason is really the medical plans that are available here. I think that you just get more coverage in the States, and coverage is just not available in Canada. Right. So I'm sure that plays into it.
Let me say that all the genomic tests are in the NCCN guidelines and approved by Medicare in the United States, approved by CMS.
I have a question that's I need to know an answer to. And I think all the men on this call might want to know the answer to this question. And that is, if I'm going to do a blood draw for my PSA, I want them to do everything. I want the PHI test. I want the, the 4K, the free PSA. I mean, I think the list is about 8 or 9 assays
Yes.
out of a blood test. What is a good list? If we're going to draw our blood anyway, let's get as much information as we can. What's the
Yeah.
list?
Well, there are a number of tests on the market, blood tests, prostate health index, free PSA, prostate health index, OPCO 4K, and one that's been developed here in Cleveland is called ISO PSA.
Okay.
And all of them all of them address the limitation of PSA. PSA is prostate specific, but it's not prostate cancer specific.
Very good.
Most men in their 50s and 60s who have an elevated PSA actually have BPH and not prostate cancer.
Right.
All of these tests are better at predicting whether or not there's a prostate cancer present. My routine practice for screening is PSA and percent free PSA. But and we've used and PHI and OPCO and ISO PSA have been used as a reflex test, meaning in the past, I had a guy in his 50s who had a small prostate and a PSA of 5. I would recommend a prostate biopsy.
Okay.
In the UK, they recommend an MRI for anybody with a PSA above 3. And if the MR is negative, no biopsy. And if the MR is positive, biopsy. That's one way. In the US, because MRI generally is not covered by insurance, we recommend one of these reflex tests, prostate health index, OPCO or ISO PSA, and get that before deciding on a biopsy. So what they allow us to do is to further risk stratify whether or not there's a high-grade cancer present and whether or not it's worth doing a biopsy. That's what they used before. And now, having said that, I'm a big fan of ISO PSA, which is not widely commercial available yet. And let me just do a disclosure here. I had nothing to do with the science behind ISO PSA. It was somebody else's idea, a company called Cleveland Diagnostics. I have no personal financial interest in this test. Cleveland Clinic, where I work, owns part of this company. And I have been the lead clinical investigator on this, and we're just putting together the data. In someone with a PSA between 4 and 100, where we used ISO PSA, we were able to avoid doing biopsies in 55% of men. That is a good thing. And PHI and OPCO have only been able to avoid biopsy in about 30 to 35% of them. So I think ISO PSA is going to be a game changer. And we are working on developing the trials to determine whether or not it could substitute or replace PSA as an initial screen. We don't have that data yet.
Thank you. Great.
I have
Great answer. Go ahead. Go ahead, Jeff.
Doctor, okay, you hit on a great point. May I ask, of course, we have your esteemed Canadian colleague, Dr. Klotz.
Yep.
He seems to favor Sentinel. You have indicated ISO PSA. Could you guide us on maybe 3 or 4 of these tests that will help, if you will, put the icing on the cake in regards to our status on active surveillance?
Let me say this: PHI, OPCO, and ISO PSA have not. Let me say, ISO PSA hasn't been tested in active surveillance. The other 2 in the canary cohort were not useful in predicting who reached a trigger for biopsy. Laurie Klotz has been working on this microRNA, I think it's a urine-based test, that looks very promising. And in fact, it looks too good to be true because the published data suggests that it's 90% accurate in picking up grade 7 cancer. And there's no biomarker out there that's that accurate. And so there's some skepticism about that, even though I think it's great technology and biology. But here's the other issue that I personally don't know. Laurie might know the data on that. Not all grade 7 cancers need treatment. It's not clear to me yet whether this new test can distinguish a good grade 7 from a bad grade 7. So As I said earlier, I think the major challenge in surveillance now is deciding how often to follow someone, how often to biopsy them, to get past the limitations of the sampling error biopsy. So sort of liquid biopsy approach is exciting, but it's not mature yet, I would think. So, let's talk again in 3 or 4 years when we have more data. It's likely that things will continue to change.
Thank you.
I've got a couple of questions, and certainly if anybody's got one, just raise your hand or just say, hey, I have one standing by, David, and we'll get to you. You may have explained this, but you used a word on your slide, cribiform.
Yeah.
I'm not that familiar with what that is.
Yeah. It's a certain pattern of cells. It's a certain way that some prostate cancer cells that forms a pattern that I think of like peanut brittle, is what it looks like to me. And it's a pattern that is associated with high-grade molecular features. And in fact, if you look at the genes and the chromosomes in cribiform histology, it has the same pattern as men with metastatic prostate cancer.
Wow.
Who have failed hormones.
Wow.
So if you have cribiform on a biopsy, that's bad.
Okay.
And that's not a good candidate for surveillance. And the other interesting thing, we haven't published all this data yet, is that Oncotype can pick up the cribiform histology. And
Great.
so, yes. And so this is a common problem, which is that community-based pathologists who read the vast majority of prostate cancer biopsies around the world don't report on cribiform histology. They don't recognize it, or they're not trained to read it. And so there are 2 studies that are published that show that if you use Oncotype in addition, you can identify the bad cancers that have cribiform histology in them without needing an expert pathologist. So remember what I said before about reading an MRI, you need an expert to read the MRI. You need an expert pathologist, but a biologic-based test is objective. You don't need to have the most experienced person there. So there's going to be, stay tuned. We're working on some publications that I think are really going to upend the way prostate cancer is graded and change it. And if you have Gleason 6 or 7 and no cribiform and a low genomic score, that's a cancer that doesn't need to be called a cancer and probably doesn't need to be treated and may not even need to be followed. We don't know that yet.
Well, that's wonderful potential. Thank you for that. It gives me hope.
David?
Yes, sir.
I just wanted to ask Dr. Klein a question about long-term active surveillance. There are a number of us who have been on active surveillance for, I guess upwards of 15 years.
Yes.
What's your comment on that? And how would you treat men like once you're up at that? If
I would say first, I would say congratulations. Second, I would say we need to figure out who you are at the beginning so that we can say, I don't ever need to see you again, right? Or I can say, I'll see you again in 5 years, that sort of thing. So I think that's terrific. And we just need to learn from that. We'd have to go back and look at the original characteristics of your biopsy. What was your PSA? What was your biopsy? Probably 15 years ago, you didn't have an MRI initially. That's the sort of predictive data that the artificial intelligence algorithms are working on. So we're going to get to the point, I think, where we will be able to predict for an individual, yeah, your biopsy shows a little low-grade cancer. It's nothing to worry about. I don't need to see you again.
Great, thank you.
Thank you, Phil. Doctor, there's 4+3s and there's 4+3s, right? Do the pathology readers put a percentage after that 3? In other words, there's a difference in my mind of if you've got a 4+3 where the 3 is only 5% of the sample and a 4+3 where the 3 is 45% of the sample, that's almost close to a 3+3, but not. How are you stratifying those 4+3s?
3 plus 4 is that?
Or 3+4 or 4+3? The 7, the Gleason 7. It sounds like there's, you need, if you're gonna, once you get beyond 6, the 7 is close to 6, and there's the 3+, like you said, thank you, Phil. There's a 3+4, 7, and then there's the, you know the point I'm making. It's the
Yeah.
percentage of the 3s and the
It was.
percentage of the 4s. And are they doing that kind of fine tuning? And is it in every report? I don't think I remember seeing it in my first pathology report.
So the percentage of pattern 3 and 4 should always be reported by expert pathologists, always.
Okay.
So you raise an interesting question is if it's 45% pattern 3, 45% pattern 4 and 55%, right? I mean, where's the line?
Mhm.
So this really shows a limitation of histology and biopsy sampling. And so there are two things I look at. Are there cribriform or intraductal glands present? We know that those are aggressive cancers. Doesn't matter how much 3 or 4 is in the system. And genomic testing can reveal this. Genomic testing will tell you whether or not you got a bad cancer. So,
Okay. A follow-up to that, I think everybody in the audience might be interested in this. I don't know if I'm putting you on the spot, but my first pathology report was done by a hospital,
yes.
and apparently, and I imagine that pathology department is looking at about 120 or more different cancers every day.
Right.
But my second pathology report, where I got my second opinion, was done at a urology department, pathology department. And in my mind, that was a much more accurate read. Is that fair to say in general? I mean, just to give everybody in our audience a sense of who's reading your pathology.
Well, so who's reading your pathology is critically important, and you need an expert. And it doesn't matter whether they practice at a hospital or independently or with a urology group. It's all about who the expert is.
Okay.
But again, we've all seen that. I mean, I have every biopsy on every referred patient re-reviewed by our experts. Most non-experts don't talk about cribriform histology. And the last thing I said, if you remember that slide that I showed that compared genomics to MRI, biology is objective. So if you measure the biology with the genomic test, it doesn't matter who the pathologist is.
Good point. Thank you. That's a great clarification, and thank you for really highlighting that clarification again. I mean, it's really now finally sunk in for me. We're getting ready to wrap up. We just have a couple of things we want to announce at the end. Is there anybody that has a pressing question that they'd like to bring forth before we go into our wrap-up mode? I see somebody raising their hand. I don't know who it is, but go ahead, take the mic.
Okay, many people have had treatment with radiation. I'm in a category that I've had 5 years where my PSA is less than 0.06. Is there any need for people who have had radiation treatment to go on to active surveillance after that period of time when it's should it be started? Because there's a high probability of gene mutation similar to what occurred in the past going on. I know of 2 people who have suddenly died because it's metastasized to bone.
Yeah, so PSA is a good indicator of what's going on in your prostate after treatment. So I'd recommend a PSA every 6 months, and that's all you need to do. That's not, you're treated, so that doesn't mean that's not active surveillance. That's just post-treatment surveillance.
Okay, Dr. Klein.
Yes.
Hi. You've made reference throughout the talk to high genomic scores and low genomic scores. What's the sort of the cutoff? What do you consider a low genomic score?
So it depends on the test. So for Decipher is reported as low, intermediate, and high. And the cutoffs are 0.4 and lower or low, 0.4 to 0.6 is intermediate, 0.6 and above is high.
Well, I had Prolaris.
Okay, so yeah, Prolaris reports a little differently, and I don't use it, so I'm not quite as familiar with the report. So they report a percent likelihood, I think, of getting metastasis. So, down around 2 or 3% is low. I don't know what they consider high.
Okay.
And Oncotype is probably dichotomous now. If you're below 25, that's a low score. If you're above 29, that's a high score.
Okay, mine was 3.6.
Yeah, so my recollection is that's probably intermediate. That's probably right on the border. Yeah.
Okay.
Thank you, Frank.
So Dr.
I'm sorry, would that make me eligible for active surveillance, or would it make me more likely a candidate for treatment?
It would, you could be eligible for surveillance if you don't have cribriform histology on your biopsy, if you don't have a lot of patterns 4, depending upon your age and general health and that sort of thing. But with men with intermediate scores, I follow a little more closely than men with low scores. So I think surveillance is fine. I would
Dr.
ask
Klein,
you to stay on that. Yes, sir.
Okay, thank you.
what part does the free PSA play in the equation?
Free PSA is an indicator of the presence of cancer. It has not had prognostic value in determining the aggressiveness of the cancer. So it's generally used as whether or not you should have a biopsy. That's all.
Okay, I'm going to take the microphone now, and anybody that has an additional question, rest assured, send it to us. Send it to our address, and we will get back to you with an answer. We know that there may be more questions out there currently or after this, our talk today, and we want you to know that we're going to follow up with you. So don't worry that you weren't able to get your question in. Send it in to us, and we will, as a board, address it as best we can. And if need be, maybe we'll reach out to one of our urologist contacts. But what I want to do is go into a wrap-up mode now, thanking Dr. Klein. We have, let me see, I want to just share my screen here for a second. If I can do this. Okay. Host disabled participant screen sharing. Can someone re-enable my screen sharing capability, or I can just speak to it and not worry about it? Okay.
Otherwise, David, I'm happy to jump in if you want me to.
That's what I want to do. I'm going to introduce Jeff right now, who's going to say a word from our sponsor.
Yes, okay, I'm holding up a gold coin. Well, I'm pretending to. Anyway, thank you, David. I'm the one who reminds everyone that we're a registered charity, 501c3, etc., but we can only survive on your donations and sponsorships. We're a place for information and answers for men with prostate cancer or who are being diagnosed. Your gift will be used to build our vast resources, such as we're learning today, and expand our base of answers, providing the knowledge that you need when you need it most. We are also fiercely independent and not influenced by anybody in the industry and their funding. Now, we provide you with information and answers on the latest developments in the form of our newsletter, blog posts, and webinars such as today, presented by experts such as this Dr. Klein in the field of prostate cancer. Knowledge equips you with information and answers that prepares you to intelligently discuss this diagnosis with medical professions and your family. Help all of us with your generous support by going to our website, aspipatients.org, and click on the support tab and give as much as you can. We certainly need your support. We're going to continue to get this great information, and thank you, everybody.
Thank you, Jeff. And can you still hear me on the mic? Have I lost you?
Yes. No, we're here.
Oh, you can.
We
Okay.
got you.
I've
You're
lost
good.
my visual here for a second. I just want to say we can turn the microphone over to Howard for a second to talk about our next event. If you're off mute, otherwise I can make this
I'm
announcement.
here.
Okay.
I'm
if you could
ready.
Just take a short 30-second commercial for our upcoming event.
Okay. On August 28th, we're going to prove that our last name really is international. Active Surveillance Patients International. We're going to have another discussion on transperineal versus transrectal. And all of our speakers are from places far away from the United States. We're having one British, 2 Norwegian speakers, and a 4th speaker from Australia on video because of the time difference. And the discussion's going to be, you know, the advantages of transperineal versus the disadvantages of transrectal. And one of the speakers is going to be a woman whose father died from sepsis caused by a prostate biopsy. And these people are all changing the world. And as Dr. Klein said, his famed organization has already made that switch. So why don't you join us on August 28th, as if your life depends on it, because it might. And the questionnaire you'll receive, you'll be able to pre-register, which will reassure the marketing people that we're going to have enough people attending. So that's it, David.
Thank you very much. This is a wrap. Again, Dr. Klein, we cannot thank you enough. We know you're really, really busy, and thank you for taking the time to be with all of us. There are a lot of us here that learned a lot. We'll be taking it out to our communities and to our doctors and to our families. So we want to thank you very, very much. And to everybody out there, thank you. We are now in a wrap-up mode. We look forward to connecting with you at the next event. Thank you and goodbye, and have a great weekend, and be healthy and stay vigilant in a peaceful way. Take care. Bye-bye.